Previously, we discussed the etiological causes of GERD. Basically, we have just two mechanisms that cause reflux of gastric content into the esophagus. First of all, it's decrease in resistance of the lower esophageal sphincter, and also its increase in intra-abdominal pressure. GERD has two major typical symptoms. It's heartburn, which is substernal pain, and also its regurgitation. GERD has two major types. If gastric content, including hydrochloric acid, do not cause erosions, we call this non-erosive reflux disease, which is present in 90% of patients with GERD. But sometimes non-erosive reflux disease can progress, and once reflux causes erosions, we call this erosive esophagitis, and this progression occurs just in 10% of patients. Also, we have to know that GERD can be complicated by Barrett esophagus, which is metaplasia, and Barrett esophagus with time can cause Adenocarcinoma, which is a type of esophageal cancer. And to explain how all these features develop, we have to know the pathogenesis of GERD. So here we have esophagus. Esophagus has three layers. It's mucosal layer, submucosal, and adventitia. Also, esophagus has lower esophageal sphincter. In normal condition, once food passed into the stomach, sphincter should be fully closed. But in GERD, some pathogenic factor, as smoking for example, can cause partial relaxation of the lower esophageal sphincter. Also, in overweight person, increase in intra-abdominal pressure can overwhelm the resistance of the lower esophageal sphincter, and in this state, sphincter becomes only partially closed. And exactly this small feature will cause the whole cascade of problems. Inside the stomach, we have parietal cells. Parietal cells have hydrogen-potassium ATPase, which is a specific transporter that produces hydrochloric acid. And also, parietal cells have histamine type 2 receptor, and histamine through the H2 receptors can markedly increase the secretion of hydrochloric acid by parietal cells. Through this open space in lower esophageal sphincter, food with hydrochloric acid can reflux back from stomach into the esophagus. Moreover, hydrochloric acid can reach not only esophagus, but also acid can go further into the oral cavity. We call this regurgitation. And once hydrochloric acid appears in the oral cavity, we immediately sense the acidic taste in the mouth, or we call this bitter taste. And exactly the presence of acidic taste in the mouth tells us about regurgitation. So when patient comes for consultation, we do not ask him, do you have regurgitation or not? We ask him, do you have acidic or bitter taste in the mouth? And exactly acidic taste in the mouth will tell us about regurgitation. Esophagus has only two defensive mechanisms against hydrochloric acid. The first line of defense against acid is saliva. Salivary gland produces saliva. Saliva goes into the esophagus, where saliva creates a superficial lining of bicarbonate. The concentration of bicarbonate in this defensive layer is very small, so this defensive lining is very weak. But it's the only chemical protection against acid that esophagus has. And also, it's the reason why GERD causes hyperproduction of saliva. We call this hypersalivation. So, increase in saliva production serves as defensive mechanism against hydrochloric acid in the esophagus. Also, we have to know that in mucosal layer we have nociceptive receptors. Now, in some people, these receptors are located more superficially. In other people, they are located in more deeper regions. And as we'll see further, these anatomical differences make a huge difference. Once hydrochloric acid appears in the esophagus, acid begins to penetrate through the bicarbonate line of defense into the mucosal layer. And now everything depends on location of nociceptive receptors. In case if nociceptive receptors are located superficially, hydrochloric acid causes very strong irritation of nociceptive receptor, which results in severe heartburn. So this category of patients are hypersensitive to any acid in the esophagus. But if nociceptive receptors are located in more deeper regions, in this case, only a few acidic molecules can penetrate that deep, and small amount of acidic molecules will cause mild irritation of nociceptive receptors, and thereby it will cause just mild heartburn. And absence of esophageal erosions combined with the presence of GERD symptoms as heartburn and regurgitation we call non-erosive GERD, which is by far the most common form of GERD, and this form is present in approximately 90% of patients. Also, we have to know that in some people, receptors can be located so deep that they will not have heartburn at all, just regurgitation. So, how we can classify syndromes of GERD? GERD syndromes can be divided on esophageal and extraesophageal. Esophageal syndromes are divided on symptoms that are caused by GERD itself and complications caused by GERD. Symptoms that are caused by reflux itself we divide on typical and atypical. We have just two major GERD symptoms. It's heartburn and regurgitation. It's the most common and the most specific GERD symptoms. Because recall that in the esophagus, the irritation of nociceptive receptors by hydrochloric acid causes pain, and such pain we call heartburn. And also in the oral cavity, hydrochloric acid can cause acidic or bitter taste in the mouth, and this feature we call regurgitation. So heartburn and regurgitation are two essential symptoms. If they are not present, then the diagnosis of GERD is highly unlikely. And reflux, as a defensive mechanism, provokes hypersalivation, which is also, according to some guidelines, belong to atypical symptoms. All other symptoms we call atypical, because they are possible but they are non-specific to GERD. They also can be present in a bunch of other disorders. If GERD is present for a prolonged period of time, GERD can cause some serious complications. Initially, hydrochloric acid can cause damage to the mucosal layer, and damage to the mucosal layer we call erosion. GERD with the presence of erosions we call erosive esophagitis. Erosive esophagitis is classified based on Los Angeles classification. Grade A is the presence of a local small erosions. Grade B is the presence of a local big erosions. Grade C is the presence of a large erosions, but they affect less than 75% of esophageal circumference. And grade D is a very large erosions that affect more than 75% of esophageal circumference. With time, under the constant damage by hydrochloric acid, injury can extend even to the submucosal layer. And injury that affects mucosa and submucosa we call ulcer. Now ulcer is a different beast. Erosions can be healed without problem, but with ulcers we have two big problems. First of all, in a good scenario, ulcers can be healed. But healing occurs by fibrous tissue that fills this damaged area. The problem with fibrous tissue is that it's basically a scar. It's a very dense, rigid tissue, and deposition of very dense tissue in the esophagus wall can cause stricture. The bad scenario is that with time, hydrochloric acid can even cause damage to adventitia, and with injury to adventitia, in some circumstances, perforation of the esophagus can occur. It's a very rare complication, but certainly a very serious one. Another complication of GERD is Barrett esophagus. Constant injury by hydrochloric acid provokes esophageal epithelium to adapt. The problem is that esophageal epithelium do not have defensive mechanisms. but the organ that has epithelium with protection against hydrochloric acid is intestine, because intestine has goblet cells that produce massive amount of bicarbonate. So areas of esophageal epithelium that are most frequently damaged by hydrochloric acid begin to transform. So they gradually transform esophageal epithelium into the intestinal epithelium, just to protect esophageal mucosa from hydrochloric acid. This process we call metaplasia, and esophagus with metaplasia we call Barrett esophagus. The problem with metaplasia is that with time, metaplasia can progress to adenocarcinoma. On this image, we can see normal esophageal squamous epithelium. And then, under the effect of hydrochloric acid, esophageal epithelium begin to transform into the intestinal epithelium. And the major feature of intestinal epithelium is the presence of goblet cells that produce bicarbonate. And with time, this transformation to intestinal epithelium can progress even further. Initially, we call this low-grade dysplasia, then it's high-grade dysplasia. And in the end, Barrett esophagus can transform to adenocarcinoma, which is a very dangerous subtype of esophageal cancer. Recall that we have just two types of esophageal cancer. It's squamous cell carcinoma, where the major risk factor is smoking, and adenocarcinoma, and the major risk factor of adenocarcinoma is GERD. On this endoscopy image, we can see normal mucosal layer of the esophagus. Then, if GERD progress, we can see normal epithelium combined with areas of erosions. On this image, we can see huge affected area with erosions and probably even ulcers. On the last image, there is very distinct adenocarcinoma. So the second group of esophageal syndromes are actually complications of GERD. It's reflux esophagitis, strictures, Barrett esophagus, and adenocarcinoma. The second and the last protective mechanism of esophagus against hydrochloric acid is esophageal motility. Once hydrochloric acid appears in the esophagus begin to contract, and by this esophagus try to push hydrochloric acid back into the stomach. Together, secretion of saliva and esophageal motility form so-called esophageal clearance, which is basically the only defensive resource that esophagus has. So, for example, patients with Sjogren syndrome or scleroderma have impaired esophageal clearance, and thereby they are more vulnerable to GERD. The problem with regurgitation is that presence of hydrochloric acid in the larynx or in the oral cavity is completely non-physiological, and this can cause so-called extraesophageal symptoms. Extraesophageal symptoms are divided on a more common and less common. To the most common extraesophageal symptoms we include reflux cough, laryngitis, reflux asthma, and dental erosions. Less common symptoms are sinusitis, pulmonary fibrosis, pharyngitis, and recurrent otitis media. Probably the most common extraesophageal manifestation of GERD are dental erosions. On this image, we can see multiple dental erosions caused by GERD. And the reason why GERD causes dental erosions is that hydrochloric acid basically removes saliva from the tooth surface due to the higher surface tension. As a result, now acid comes in direct contact with tooth. Once this happens, immediately demineralization occurs. And demineralization causes formation of so-called dished-out lesions. On this image, we can see normal larynx. And on the next image, we can see laryngitis, which is characterized by edema and erythema of the larynx. Also, chronic laryngitis can cause voice hoarseness, which is a common feature of GERD. So, to summarize the clinical symptoms of GERD, according to a current American guideline, we have just two major GERD symptoms. It's heartburn and regurgitation. If both these symptoms are absent, then probably it's not GERD. And also, we have extraesophageal symptoms. The problem with extraesophageal symptoms is that they are non-specific. They can be provoked by GERD, but it's very hard to say for sure. The most common diagnostic method that we use in GERD is the PPI trial. We use this approach if patient has no alarm symptoms. In this case, we just prescribe PPIs for 8 weeks, and if symptoms resolve, then it's GERD. If alarm symptoms are present, then we use endoscopy straight away. The greatest benefit of endoscopy is visualization. By endoscopy, we can determine anatomical defects as erosions, ulcers, and so on. So PPI trial and endoscopy are the only initial diagnostic approaches that we use in GERD. To verify Barrett esophagus or adenocarcinoma, we have to perform biopsy, because only by histological examination we can determine the degree of dysplasia and the presence of malignant cells. Esophageal manometry we use if endoscopy do not show anything, PPIs do not help, but we still suspect GERD due to the motility disorder, as achalasia or scleroderma. Basically, by manometry we can determine the ability of lower esophageal sphincter to constrict. And we know that in scleroderma and achalasia, the contractility of lower esophageal sphincter becomes compromised. So in this case, we can determine decrease in tonus of lower esophageal sphincter, which is a sign of GERD. pH monitoring we use in case of absence of typical symptoms and presence of atypical symptoms. In this case, as we said, the diagnosis of GERD is unlikely. But to say for sure that it's not GERD, we have to analyze the changes in pH inside the distal part of the esophagus. If during the 24 hours pH remains normal, it's not GERD. But if we determine decrease in esophageal pH, then reflux is present, so GERD is confirmed. Also, by this method, we can determine the frequency of reflux. So this method is like the last reserve. The last method of diagnosis is barium swallow, and this method we use just in case of suspected anatomical abnormalities, as strictures, Schatzkerin, or severe dysmotility. So if we suspect stricture, we can use barium swallow, which can help us to determine the narrowing of the esophagus caused by a stricture. The treatment of GERD consists of lifestyle modifications and drugs. And GERD is one of the disorders where lifestyle modifications plays a crucial role, and drugs are used just to relieve symptoms. So why lifestyle modifications are so important? Because we know that the only reason why reflux occurs is pathological decrease in tonus of lower esophageal sphincter or pathological increase in intra-abdominal pressure. If we do not correct them, reflux will occur again and again. First of all, patients should be on diet. We exclude fatty meals, carbonated beverages, and citruses. And the portions of meals should be small. Diet is crucial because it can help to lose weight. With weight loss, intra-abdominal pressure decrease, and with decreasing intra-abdominal pressure, the frequency of GERD episodes decrease. Also, patients should stop smoking. In this case, we prevent relaxation of the lower esophageal sphincter. And with increasing tonus of lower esophageal sphincter, the frequency of GERD episodes decrease. Excessive exercises can also cause increase in intra-abdominal pressure, so we should avoid them. And sleep with head elevated can partially decrease the amount of hydrochloric acid that incomes to the esophagus. But which drugs do we use during this correction of lifestyle? First of all, the major drug in GERD treatment is PPIs. Proton pump inhibitors block hydrogen-potassium ATPase. By this, they decrease hydrochloric acid secretion, and the lower the amount of hydrochloric acid, the less severe becomes clinical symptoms. The second major class of drugs are H2 blockers. This class of drugs we use in addition to PPIs in case of night symptoms. H2 blockers block H2 receptor on parietal cells. The secretion of hydrochloric acid decreases, and the lower the secretion of hydrochloric acid, the less severe becomes clinical symptoms. So usually we prescribe just PPIs. But if person already on PPIs and he mentioned heartburn at night, in this case we add to PPIs H2 blockers. The next drugs are prokinetics. It's metoclopramide, prucalopride, and etopride. And also we can use baclofen, which is a GABA agonist. Baclofen stimulates the contractility of the lower esophageal sphincter. The stronger is the contractility, the higher is the resistance of the lower esophageal sphincter. So by this we can prevent reflux episode. And prokinetics stimulate esophageal motility, and also they stimulate the contractility of the lower esophageal sphincter. Both these effects protect against reflux. And the last drug is sucralfate. This drug is a mucosal protection agent. Sucralfate basically donates bicarbonate to the superficial protective layer. What we have to know about sucralfate is that it's a drug of choice in pregnancy. From etiology, we know that pregnancy is one of the major risk factors of GERD. So to decrease the severity of reflux in pregnancy, initially we use lifestyle modifications. But the first drug that we prescribe is sucralfate, then H2 blockers, and if these do not help, then PPIs. But after pregnancy, symptoms will resolve even without treatment. So imagine the situation when patient comes to you with a heartburn and regurgitation. What will be the steps in management of this patient according to current guidelines? Initially, we have to determine if he has alarm symptoms or not. Alarm symptoms are the list of symptoms that tell us about the possible cancer or bleeding. If even one of the alarm symptoms is present, then we refer this patient to endoscopy. But if the alarm symptoms are absent, we prescribe PPI trial, which is PPIs for 8 weeks. And as we know, PPIs should be taken 40 minutes before meal. In good scenario, symptoms resolve, and with time we can even discontinue PPIs. They will be taken only on demand. In bad scenario, PPIs would not relieve symptoms, and in this case we discontinue PPIs and refer this patient to endoscopy. Also, if after complete resolution symptoms will occur again, we also discontinue PPIs and refer this patient to endoscopy. In bad scenario, on endoscopy, we will find erosions LA grade B, C or D. In this case, we can confirm the diagnosis of GERD. But if endoscopy will be normal or it will be just A grade according to LA classification, in this case, we should perform reflux monitoring. And if we determine that pH inside the stomach decreases from time to time, and we know that it's a characteristical feature of reflux, we can confirm GERD. But if reflux monitoring do not show alterations in esophageal pH, then we should consider another pathology. And also, we have the scenario where a patient will complain over extraesophageal symptoms as laryngitis or dental erosions. In this case, everything depends on typical GERD symptoms. If heartburn and regurgitation are present, then we prescribe PPIs up to 12 weeks. If extraesophageal symptoms improve, we continue treatment with PPIs. But if there is no effect on laryngitis, for example, then we should question the presence of GERD. And also, if patient has only extraesophageal symptoms, without typical GERD symptoms, then the major question is GERD present or not, because it's highly likely that these extraesophageal symptoms can be caused by another disorder. So in this case, we perform reflux monitoring, and if we detect that pH inside the stomach lower than normal, we will treat GERD, and then with time extraesophageal symptoms will improve. But if pH monitoring do not show alterations in esophageal pH, probably they are caused by another disorder.